let's move on to brachial plexus injuries, which I'm sure all of you are familiar with. You've been reading about this since a very long time. Erb's palsy and Klumpke's palsy. We'll go behind why the deformities occur in Erb's and Klumpke's like they do. Right? So first thing, let's quickly review the brachial plexus. Brachial plexus has roots, trunks, divisions and cords. The roots are C5, C6, C7, C8 and T1. This is the normal, standard, average brachial plexus. Sometimes it also has a branch from C4 and sometimes it also has from T2. If it has a branch from C4, you call it a preset brachial plexus, and if it has a branch from T2, you call it a postset brachial plexus. Not very important. Remember, those are the roots. And then you have trunks. You have the upper, middle and lower trunk. And then you have divisions, 3 anterior and 3 posterior divisions. And then you have cords, lateral, posterior and medial cord. Okay, you knew this stuff. Now, we are not here for anatomy. We are here for orthopedics. So let's focus on the clinically significant branches of the brachial plexus and what they supply and what is the deformity if they get injured. So from the roots, there is one important branch that you should know, which comes from C5, C6 and C7. This branch is the long thoracic nerve of Bell. It supplies which muscle? Tell me, you know this stuff. It supplies the serratus anterior. And if there is injury to this nerve, what will be the physical deformity? Whenever you ask the patient to push against the wall, he will get winging of scapula. We've been reading about this since first year of your MBBS. Right. Now, serratus anterior, because of loss of long thoracic nerve of Bell, will give you winging of scapula. Now, there is something known as pseudo-winging. Pseudo-winging is basically winging because of any other cause other than serratus anterior weakness. Right? So what are these causes? It can be weakness of trapezius or rhomboids. It can be because of a tumor. It can be because of a malunion, or it can be because of an osteochondroma, where you get a winging of scapula for reasons other than weakness of serratus anterior because of long thoracic nerve of Bell palsy. Okay? So all of those are known as pseudo winging of scapula. And the reason I've shared this slide is because this question was asked long time ago, at least once. If you know this, great. If not, it's okay. We are interested more in brachial plexus injuries. Now, brachial plexus injuries have been simply classified based on the location of the brachial plexus injuries in terms of the clavicle. So, you have supraclavicular brachial plexus injuries, infraclavicular brachial plexus injuries, and combined type of brachial plexus injury. Supraclavicular brachial plexus injury means plexus injuries above the clavicle. Infraclavicular means plexus injuries below the clavicle. Combined means brachial plexus injury at both the parts. Now, supraclavicle, it's usually Erb's palsy. It's the most common type of brachial plexus injury and it has the best prognosis. And infraclavicle is Klumpke's palsy, and mixed has the worst possible prognosis. Okay, so what is Erb's palsy? What is Klumpke's palsy? How do you get it? Means what is the mechanism of injury and what is its manifestation? Again, everything depends on your knowledge of anatomy. Okay, so Erb's palsy, what is it? Where does it occur? Quickly review with brachial plexus here. So Erb's point is basically the point of confluence between C5, C6 and suprascapular nerve. This point is considered as Erb's point. Okay, if you have an injury at the Erb's point, what will happen is that you will lose the functions distal to this. Not all of them, some of them. And we will only talk about the ones that are clinically relevant. Okay, so what are the functions that are lost which are clinically relevant? To understand that, we need to know which nerves are clinically relevant that are lost here. First is suprascapular nerve. It will be lost. Second is axillary nerve. Third is musculocutaneous nerve. These three nerves will lose their function if you have a Erb's palsy. Okay, so see, listen. All the slides, content is written. You don't have to write down. Whenever I show the slide, you can pause the video and write it down. I want you to understand right now, friends. That's why I've prepared the slides like this. Because most of you will struggle writing and making notes. Everything is written. You can make your beautiful notes. Listen to me here. So if suprascapular nerve loses its function, quickly recall what are the muscles or the clinically relevant muscles it supply. Clinically relevant muscles it supply are supraspinatus and infraspinatus. Everything is written. Just pay attention to me. You can copy it later. Supraspinatus and infraspinatus. Yes. Supraspinatus abducts the shoulder. Infraspinatus externally rotates the shoulder. Right? Right. So when suprascapular nerve is lost, the patient will lose the ability to abduct and externally rotate. So the shoulder will go into adduction and internal rotation. Right? Axillary nerve will be lost. Axillary nerve, we recall, supplies deltoid and teres minor. Deltoid abducts the shoulder, teres minor externally rotates the shoulder. So patient will be unable to abduct and externally rotate, means the shoulder will go into adduction and internal rotation. Third, musculocutaneous nerve is lost. Musculocutaneous nerve supplies clinically significant muscles are biceps and brachialis. Biceps, brachia and brachialis. Brachialis is the flexor, biceps is the supinator and flexor. So the elbow will go into extension and the forearm will go into pronation. Right. So if you combine all of these, what will be manifestation? Shoulder will go into adduction, internal rotation, elbow will go into extension, and forearm will go into pronation. What is this deformity? This deformity. Policeman's tip or Pater's tip deformity. So simple if you know your anatomy. So Erb's point is the point of confluence between C5 and C6 at the suprascapular nerve. Nerves affected: suprascapular, axillary and musculocutaneous. Suprascapular supplies supraspinatus and infraspinatus, whose actions are abduction and external rotation of the shoulder. Axillary nerve supplies deltoid and teres minor, whose action is to abduct and externally rotate the shoulder. Musculocutaneous supplies brachialis and biceps brachii, whose action is to flex and supinate respectively. These actions are lost, and when these actions are lost, the shoulder will go into adduction and internal rotation, and elbow will go into extension, and the forearm will go into pronation. This deformity is known as policeman's tip, waiter's tip, or porter's tip deformity. And this is a baby born with Erb's palsy. How simple and logical and beautiful it is, isn't it? If you know your anatomy, nerve injuries is a walk in the park. Otherwise, you will keep struggling again and again. Right? Okay? So simple. Now the question remains, how do you get Erb's palsy? See, Erb's palsy is an injury of the brachial plexus above the clavicle, supraclavicular injury. Okay? Supraclavicular injury. So suppose this is your brachial plexus here at the neck, right? Just around here. So if you want to injure the upper roots and trunks of the brachial plexus, what kind of maneuver would you want to do? You basically want to move the head away from the shoulder, thereby stretching the upper roots and trunks. When do you get this kind of maneuver? You get this kind of maneuver here. At the time of birth, when the child has a shoulder dystocia and the gynecologist keeps on pulling the head, right? There is a stretching here. Head moving away from the shoulder. At the time of road traffic accident, when you fall down and your head hits the pavement and moves away from the shoulder, as in this case. Are you following me? Head moving away from the shoulder. Simple. You understood the mechanism. You understood which part of the brachial plexus is injured. You have understood which nerves are affected. And because you know the muscle supply of those nerves, you know what would be the deformity. That is your Erb's palsy. Okay? So far, so good. Okay? The splint that you will use in any kind of brachial plexus injury is aeroplane splint. I'll show you what it is. Don't worry. Next is Klumpke's palsy. What is Klumpke's palsy? Klumpke's palsy is injury of the brachial plexus, the lower roots and trunks. That is C8-T1. Let me just ask you, what would be the mechanism of injuring the lower roots and trunks of the brachial plexus? For upper roots and trunks, I said head moving away from the shoulder. For lower root and trunk, the shoulder should move towards the head. Shoulder should move towards the head. Only then you will stretch the lower roots and trunks. Now tell me, when will your shoulder move toward the head? We've talked about this in upper limb trauma. Hyperabduction injuries. Hyperabduction injuries. Right? Falling from height, holding on to an object, suddenly your arm will go into hyperabduction. That kind of injury. Number one. Second, birth trauma. Sometimes when there is a breech presentation, the arm will be left inside, and as you're pulling the baby out, the arm will go into hyperabduction. Okay? So lower roots and trunks will get injured. And when lower roots and trunks of the brachial plexus will get injured, what will be the manifestation? C8-T1 will be affected. Now, if you recall the remaining nerves, median nerve, ulnar nerve, and the radial nerve, all of them have C8-T1 component, but the predominant C8-T1 component is ulnar nerve. Okay, ulnar nerve. So C8-T1 component is affected means what will be the presentation clinically? The patient will have claw. And because the C8-T1 of median is also affected, the patient will have a complete clawing of hand. So median and ulnar nerve manifestation giving you complete clawing of hand. That will be there. But not just that. The patient will also have the involvement of T1. Now remember, T1 gives a sympathetic supply to the ipsilateral side of the face. The ipsilateral side of the face gets its sympathetic supply from T1, 2, 3 and 4. T1 supplies the ipsilateral sympathetic supply of the eye. So patient who has a Klumpke's palsy or lower roots and trunk of the brachial plexus palsy will present to you with a complete clawing of hand with loss of sympathetic supply of the ipsilateral side of the face, particularly the eye region. And what will be the manifestation of that? That manifestation, if you recall, is Horner syndrome. Ptosis, meiosis, and hydrosis, and loss of ciliospinal reflex. That will be the presentation. And this is how you differentiate a complete claw hand patient because of ulnar plus median nerve palsy versus a Klumpke's palsy. Because both of these patients will have complete clawing of hand. Ulnar plus median peripheral nerve injury patient as well as Klumpke's palsy. Klumpke's palsy is not a peripheral nerve injury, it's a brachial plexus injury. How do you differentiate? This patient of Klumpke will have complete claw plus Horner syndrome. How will the examiner present this to you on the exam? They will not tell you directly that the patient has Horner syndrome, because if they do, you will know what the answer is. Instead, they will say the patient has difficulty in vision, patient has diplopia, or patient is unable to open the eyes because of ptosis. That way you'll get an idea that this patient has a complete clawing of hand with some eye manifestations. This could be Klumpke's palsy. Okay, that's it. Klumpke's palsy. Complete claw with Horner syndrome. Injury of the lower roots and trunks of the brachial plexus C8, T1. Not the splint you will use in brachial plexus injuries. You will use aeroplane splint because the limb is kept as the wings of the aeroplane. Now let's move on to lower limb nerve injuries. The most important being sciatic nerve injury. Okay. Now, whenever we talk about sciatic nerve injury, if you realize the manifestations of sciatic nerve injury are basically the manifestations of common peroneal nerve injury most of the times. And the reason for this is very simple. If you take a cross section of the sciatic nerve, you will realize that common peroneal nerve component is basically the superficial component of the sciatic nerve. And the tibial nerve component is the deep component of the sciatic nerve. And whenever there is an injury of the sciatic nerve, it is usually the superficial part of the sciatic nerve that is affected or injured first, rather than the tibial component. So most of the patients with sciatic nerve injury present to you with common peroneal nerve palsy like symptomology. That is why it's better to read the common peroneal nerve injury manifestations rather than sciatic nerve injury manifestations, because that is what is more common and frequently asked on your exam. Right. Now, where does the common peroneal nerve get injured? Just around the head of the fibula, the nerve divides into a superficial and a deep branch. The common peroneal nerve around the head of the fibula divides into a superficial and a deep branch. The superficial supplies the lateral aspect of the leg, and the deep branch supplies the anterior aspect of the leg. The superficial supplies the lateral compartment of the leg, and the deep branch supplies the anterior compartment of the leg. And what are the relevant muscles there? Those muscles you will read in anatomy. But simplification of it is that the muscles on the lateral compartment of your leg basically help evert the foot. Evert the foot. And the anterior compartment of your leg basically help you dorsiflex the ankle of the foot. Okay, so what is this eversion? What is this inversion? Dorsiflexion, plantar flexion, you know. Eversion, inversion is where the confusion is. So the muscles of the superficial branch of the common peroneal nerve, basically the peroneus longus and brevis, they evert the foot. They evert the foot. And the muscles of the deep branch, that is the tibialis anterior and posterior, apart from inverting, they ankle dorsiflex. So primary action is dorsiflexion. So the common peroneal nerve is injured, the everters and dorsiflexors are gone. So foot will go into plantar flexion and inversion. Okay. So the deformity you basically get is equino varus. Equino means plantar flexion and varus is inversion. That is the deformity you'll get in common peroneal nerve injury. That is what is known as foot drop. And whenever the patient walks, because the patient is unable to ankle dorsiflex, the foot will drag on the ground. The foot will drag on the ground. And when the foot drags on the ground, the patient will be uncomfortable to walk. So what will he do? He will exaggerate the hip and the knee flexion in order to lift the dragging foot off the ground. That kind of gait is known as high stepping gait or a foot drop gait. That's it. That is what happens in patients with common peroneal nerve injury or sciatic nerve injury. because sciatic nerve, peripheral component is common peroneal nerve. So injury of the common peroneal, superficial and deep branch affected. Superficial, lateral compartment of the leg, deep anterior compartment of the leg. Everters are gone, ankle dorsiflexors are gone. So plantar flexion, equinus, and inversion, that is varus deformity. Foot will be dropped, patient will be unable to ankle dorsiflex. Every time the patient walks, he will be dragging the foot on the ground. So it will be uncomfortable. So he will exaggerate the knee and the hip flexion as he walks to lift the dropped foot off of the ground. That is known as high stepping gait. And in order to help him, we'll use a splint that is known as a foot drop splint. Okay, we'll use a foot drop splint where the splint prevents plantar flexion or equinus deformity. Okay. Another important thing I want you to remember is also the sensory supply of the superficial and the deep branch. The superficial supplies the dorsum of the foot completely, whereas the deep branch supplies the first web space. This is important. Deep branch supplies the first web space of the foot. Is that clear? So deep branch, first web space, superficial branch, dorsum of the foot. Now moving on to entrapment neuropathies. Self-explanatory name. Entrapment neuropathy. Pathology of the nerve because of entrapment. So this occurs because the nerve gets trapped. Nerve gets trapped under structures here. It can be bony, it can be soft tissue. There are many types of entrapment neuropathies, but the most common is carpal tunnel syndrome, which involves the median nerve. And when the nerve gets entrapped, what happens? The distal supply of that nerve will be affected. Okay. And if you do a nerve conduction study, what will you notice? You will notice that the velocity of the stimulus under the part which is entrapped is decreased. That's how you diagnose it. Let's start with carpal tunnel syndrome. So I will tell you what the story here would be, and then we'll read about it everywhere. Okay. The story here would be, it will be typically a middle-aged female who will come to your OPD and tell you, sir, in the middle of the night, as I'm sleeping, I'll get pain in my hand, severe pain in my hand, usually in the finger area. Usually in the finger area. Okay. Then what do? I get up and I shake my hand. And the pain is gone. Which fingers, you will ask? They will say, these fingers, the lateral 3 fingers. And they shake her hands, and she shakes her hand, and the pain goes away. And then she goes back to sleep. You ask for her occupation, and she will say someone like a typist. Someone like a typist who will be constantly putting their hand and typing on the keyboard, compressing this part of the wrist. So essentially what is happening here is that the median nerve, which passes under the flexor retinaculum, which orthopedic surgeons say, or transverse carpal ligament, which anatomists say, the median nerve passes under that and it gets compressed under it. And around that you have your carpal bones. So that tunnel is known as carpal tunnel. Let me show you. So these are your carpal bones, and this is your flexor retinaculum, and this tunnel is carpal tunnel. And this is where your median nerve will get entrapped. Okay. The most common cause is basically idiopathic. We don't know why it occurs. That is an MCQ. The most common cause is idiopathic. Other than that, yes, direct pressure over it because of abnormal ergonomics or positioning, yes. Or any pathology that can increase the pressure inside the tunnel. What could this pathology be? That any pathology that allows for accumulation of fluid, fat or blood. That will cause pressure over the median nerve. That pathology can be Colles fracture. Yes, if there is a fracture hematoma will collect, and that hematoma will compress on the median nerve. Amyloidosis, accumulation of amyloid. Gout, deposition of the crystals. Acromegaly, overgrowth of the bones. Pregnancy, accumulation of fluid. Rheumatoid arthritis, inflammation. Hypothyroidism, mixed edema. Right? All of these things basically allow for accumulation of substances or fluid in the carpal tunnel, causing compression of the median nerve. Okay, but the most common cause is idiopathic. So it will be a middle-aged female coming to you with burning, tingling and numbness and paresthesia in the median nerve distribution. These fingers. Right? Not the thinner part. Because superficial branch supplies the thinner part. The deep branch supplies the fingers. Very important. Pain is usually at the night, and the patient hangs the hand over the edge of the bed for relief. to get the symptoms of. Motor symptoms, remember, occur very late in the disease. So early on in the disease, you have sensory problems. The patient will complain of tingling, numbness, and burning sensation. Motor manifestations happen very late in the disease process, and usually, if the patient comes to you when the motor manifestations have already set in, the prognosis is usually poor because muscles have already started to die and get wasted. Please keep that in mind. Okay. So how will you make the diagnosis? This is usually a clinical diagnosis. When the patient comes to you, gives you a classical story of what happens to her, you will make the diagnosis very easily. But you can't just make the diagnosis based on the history, right? You have to confirm it clinically, and you have to do a few investigations to document the actual pathology. So what are the clinical tests that you can do? A lot of MCQs are asked here. You do something known as a Phalen's test and reverse Phalen's test. So what is Phalen's test? You basically ask the patient to hold the wrist in this position. Essentially, you are compressing the median nerve at the flexor retinaculum. So if the patient has carpal tunnel syndrome, he's already predisposed to this compression, and you ask him to hold it, to hold it for 60 seconds. And during that duration, the median nerve gets compressed, the symptoms are reproduced. You see, you'll realize that most of the tests that we perform in orthopedics are provocative tests. They provoke the symptoms in order to make the diagnosis. So this is a provocative test. It's provoking the symptoms. And the patient complains of pain and saying, yes, sir, this is the place where I'm getting sensations abnormally. This is the site where I'm getting pain on doing so. This is known as Phalen's test, and this is a reverse Phalen's test. A few more tests that you should know is a Durkan's test and a tourniquet test. Tourniquet is you apply a tourniquet at the wrist, inflate it, symptoms will reproduce. Durkan's test is the direct median nerve compression test, where you take your thumb and press on the median nerve. By doing so, symptoms will reproduce, and that is the best clinical test as asked on your NICET exam. Now I will show you 3 tests for carpal tunnel syndrome. Now, can you tell me what carpal tunnel syndrome was? It was basically the entrapment of the median nerve in the carpal tunnel, right? Now, the aim of these tests are to basically provoke the symptomology. This will be a patient who will come to me and tell me, sir, I have pain, paresthesia, tingling, dull aching pain in the middle of the night, and I get up and I have to shake my wrist for the pain to go away. And he'll classically describe the pain in the median nerve distribution area. That is the thumb, the index finger, the middle finger, and part of the ring finger. Somewhere over here. Thumb, the index, the middle, and half of the ring finger. This area he will have tingling, numbness, and paresthesia. So what will I do? I'll basically try to provoke the symptoms. So the test at hand is number 1, Phalen's test, where I'll ask the patient to flex the wrist and hold this position for roughly 60 seconds. Now the aim of this test is to basically reproduce the symptomology of carpal tunnel syndrome by manually compressing the median nerve in the carpal tunnel. Now on doing this test, he will again get the same kind of pain, the dull aching pain, the paresthesia, and the tingling and numbness in the median nerve distribution, and he will tell me, sir, this is exactly the kind of pain I get in the middle of the night. This is Phalen's test. Now, a similar test is a reverse Phalen's test, where instead of asking the patient to flex the wrist, you ask the patient to extend the wrist and keep it in this position for another 60 seconds. And again, in this posture, the median nerve is getting compressed in the carpal tunnel, and so the symptoms will be reproduced. So you have a Phalen's test and reverse Phalen's test for carpal tunnel syndrome to diagnose the median nerve entrapment in the carpal tunnel. Now let me show you another very important clinical test to diagnose carpal tunnel syndrome. And in fact, this is the best clinical test. This is Durkan's test. This is direct median nerve compression test. So all you have to do is directly compress on the median nerve for a good 30 seconds and reproduce the symptomology of carpal tunnel syndrome in the patient. And what would be the symptomology? It would either be pain, a dull aching pain, tingling, numbness, or paresthesias in the median nerve distribution area. Okay, so this is what we have to do. Ask the patient to place their hand comfortably on the table, and between the thenar and the hypothenar eminence, you place your thumb and you compress with your thumb for roughly around 30 seconds. On doing so, what happens is the pain, the dull aching pain, the paresthesia, tingling, numbness, or the burning sensation reproduces in the median nerve distribution, and the patient will tell you, sir, I'm getting the same pain that I used to get in the middle of the night. This is Durkan's test, the best clinical test to make the diagnosis of carpal tunnel syndrome. Remember, investigation of choice is nerve conduction studies, and what will you notice? The velocity of the conduction will be depressed under the flexor retinaculum in the carpal tunnel syndrome. What is the treatment? If the patient presents to you early on, you give her a splint, or you ask her to change her posture while typing, or ergonomics are improved. If the patient comes to you later in the disease, where the symptoms are not going away just by conservative management, you have to go and release the structure that is causing the compression. Usually it is the flexor retinaculum. You cut open the flexor retinaculum, the compression will go away and the symptoms will go away. Right? So the treatment is surgical release. And if the patient doesn't come to you early on, motor manifestations happen. There will be thenar wasting, and thenar wasting is a poor prognostic sign because it is already too late and the muscles have start to lose their neuromuscular junctions. Now, whenever I talk about Fallon's test and reverse Fallon's test, a lot of students get confused with Allen's test. So Allen's test is basically a test to assess the patency of the vascular flow to the hand. Now, the blood supply of the hand is basically through ulnar artery and radial artery. And whenever you have to do an intervention where you have to either catheterize the radial or the ulnar artery, or you have to perform a surgery which has a risk of injuring the radial or the ulnar artery, you want to make sure whether the hand has this flow intact or not. Because if there is only one flow, that is either radial or ulnar, that is active, and if you accidentally injure it either because of the surgical procedure or because of catheterization, you will injure the only source of blood to the hand. And eventually the whole hand will go into ischemia. In order to avoid that, you basically assess if there is a dual supply to the hand or not with this Allen's test. So what do you do in Allen's test? You basically obstruct both radial and the ulnar artery and ask the patient to open and close the hand, thereby washing away the blood, and it becomes pale. You see, if you obstruct both the radial and ulnar artery and you ask the patient to keep on making a fist, opening and closing, you will notice that it will become pale. And then when you open the radial or the ulnar, the vascularity will resume, and then you will see flushing or redness. So you do that for both the ulnar and the radial artery and assess the patency of both of them. Right? You assess the patency of both of them. Now, if the ulnar artery is not patent, what will happen? The flow will not resume on removing the occlusion over the ulnar artery. And if the radial artery is not patent, the flow will not resume if you remove the occlusion over the radial artery. This is a very important test to basically help you assess the patency of ulnar and radial artery. And this is a short video showing you how it is done. You occlude and then you let go of ulnar and assess it, and then you can let go of radial to assess it. Okay, it's done step by step. This is your Allen's test only to assess the patency. Now, apart from the entrapment neuropathies like median nerve getting entrapped in the carpal tunnel, there are other nerves that can also get entrapped. I have a table for you, but a few very important ones are meralgia paresthetica that has been asked. Meralgia paresthetica is basically entrapment of the lateral cutaneous nerve of the thigh under the inguinal ligament. Now, this is an important thing because it's seen in males, particularly males who wear tight jeans or tight belts. And because of this tight jeans and tight belts, the lateral cutaneous nerve of the thigh get entrapped under the inguinal ligament. And because of this, the patient will have burning sensation over the anterolateral aspect of the thigh. Okay, anterolateral aspect of the thigh. This is known as meralgia paresthetica. Then there is something known as piriformis syndrome. It is because of entrapment of the sciatic nerve under the piriformis muscle. You have something known as Morton's neuroma. That is a digital neuroma forming between the third and the fourth digits of your foot. And there is a cubital tunnel syndrome, which is nothing but an entrapment neuropathy of ulnar nerve in the cubital tunnel. There is a Guyon's canal syndrome, which is nothing but an entrapment neuropathy of the ulnar nerve in the Guyon's canal. This table will help you answer those MCQs. All of the important neuropathies because of entrapment are mentioned here, and the sites of their compression also mentioned here. You can pause, you can take a screenshot, you can write it down, and a lot of MCQs are asked. A few important ones are carpal tunnel syndrome, cubital tunnel, Guyon's canal, meralgia paresthetica. And these are the ones that are very, very important for your exam. Now, two more pathologies that are like entrapment but are not necessary of only the nerve that I want to discuss. One is the popliteal artery entrapment syndrome. This is also known as exercise-induced claudication. So what happens here is that certain individuals, because of some congenital anomaly, have their medial head of gastrocnemius wrapping around the popliteal artery. Okay, so the medial head of gastrocnemius wraps around the popliteal artery. Now, in these individuals, normally nothing would happen. But suppose this individual becomes an athlete and his gastrocsoleus muscles, that the calf muscles, are hypertrophied. Whenever this person performs an activity or exercise or runs, these hypertrophied muscles will cause kinking of the popliteal artery. And because of this kinking of popliteal artery, what will happen? The distal flow of the popliteal artery will get compromised. The patient will complain of pain, of claudication. That is your popliteal artery entrapment syndrome. So, gastrocnemius hypertrophy seen in athletes, a popliteal artery compression, ischemic pain, where on the posterior aspect of the leg, right? Because that is where the popliteal artery supplies. Now, in terms of popliteal artery getting injured, there are a few more important MCQs that are asked. What is the most commonly injured artery in the body? Overall, it is popliteal artery. And what is the cause? It is the knee dislocation or the distal femur fracture that will injure the artery. In the upper limb, the most commonly injured artery in your body is brachial artery, and the cause is mostly supracondylar humerus fracture, which we have read in upper limb trauma. These are a few commonly asked MCQs. So, popliteal artery entrapment syndrome, the problem is the claudication because of entrapment of the popliteal artery. Pain will be on the posterior aspect of the leg. And the last entrapment condition that we have to discuss is thoracic outlet syndrome. It's basically the obstruction of the structures passing out of the thoracic outlet. So what are the structures passing out of the thoracic outlet, and what are the boundaries of the thoracic outlet? The boundaries of the thoracic outlet are very simple. There is anterior and posterior scalene, clavicle, and the first rib. Okay, so clavicle and the first rib, anterior and posterior scalene, the structures are passing through. What are those structures? You have your brachial plexus, your subclavian artery and vein. The most commonly obstructed or occluded structure would be your brachial plexus. So these patients with thoracic outlet syndrome will have neuropathic manifestations more than arterial or venous manifestations. Arterial and venous manifestations are basically manifestations of ischemia. Pulse will decrease, pain of claudication will be there, compression of the brachial plexus will give you pain and weakness. Now, why does it occur? Usually it is because of abnormal first rib, or usually because of hypertrophied scalene muscles, or usually because of a tumor in the proximal aspect or the epiphysis of the lungs. Now, none of that is important. What is important here is how do you make the diagnosis? You see, thoracic outlet syndrome is basically a clinical diagnosis. It's the manifestation of obstruction of structures around the neck, and the pain would be in the upper limb. Right. So there will be a patient who comes to you with pain or weakness in the upper limb. The pain can be neuropathic or claudication pain. A claudication pain can be assessed by loss in pulse or decrease in pulse pressure. And neuropathic pain means the patient has neuropathy as well. So this will be a patient who comes to you with an upper limb pain, and this pain is on particular posturing of the upper limb. Okay. If you've ruled out that there is no pathology of the first cervical rib, or there is no pathology in the upper lobes of the lung, it is usually because of obstruction at the thoracic outlet. So you need to know what these tests are, because MCQs they ask you these tests. So the first test that you can use to diagnose thoracic outlet syndrome is Addison's test. And what do you do in Addison's test? Basically, you look for pain and pulse. These are the two things, because both these things or one of these two things will be exaggerated if you obstruct the thoracic outlet. Your aim here in thoracic outlet syndrome testing is to provoke the symptoms. Like I said, most of the tests in orthopedics are provocative tests. You are provoking the symptoms here by obstructing the thoracic outlet. So how do you go about doing it? In Addison's test, you abduct and externally rotate the shoulder, and you keep your hand on the pulse. When you ask the patient to extend the neck and turn the head towards the pathological side that you're assuming is pathological. And if you do this, the thoracic outlet will narrow down and the symptoms will be reproduced. That's it. So abduct and externally rotate the shoulder and extend the elbow. Turn the head towards the affected side and extend the neck. You will notice that there is decreased pulse or claudication pain. Provoking the symptoms, thoracic outlet syndrome is confirmed. If you ask the patient to turn the head to the opposite direction instead of the same direction, you call it the reverse Addison's test or Halsted test. Again, remember, Addison is not Allen. Allen's is for patency, and they ask a lot of MCQs there, patency of ulnar and radial nerve. Addison is for thoracic outlet syndrome. Okay, thoracic outlet syndrome ka ek ho Addison's, and then there is something known as reverse Addison's test. Then there is something known as hyperabduction test by Wright's. Hyperabduction of the shoulder. That's all you need to do. Hyperabduct the shoulder and extend the neck. Symptoms will be reproduced. So either there will be decrease in pulsations or the pain will exaggerate. Wright's hyperabduction test. And Roos test. This has been asked on your exam, both as an image-based question and a video-based question, where you ask the patient to abduct the shoulder and flex the elbow and keep on opening and closing the hand for a few minutes. The symptoms will reproduce. This is a short video of that test that is being performed, and the MCQ actually had a video where they asked you, what is this test? The answer is Roos test. And where do you perform it? You perform it to diagnose thoracic outlet syndrome. Now I will be demonstrating the Roos test for you. This is a test that we perform for the thoracic outlet syndrome. Now if you recall, in thoracic outlet syndrome, there is neurovascular entrapment at the thoracic outlet. In this test, you can either have the patient standing or in sitting position, and you ask the patient to abduct both the shoulders completely to 90 degrees. After abduction, you ask them to externally rotate it as much as possible, and then flex the elbow to 90 degrees and open and close the hands or the palms continuously for 3 minutes. Now what happens is, on performing this action for 3 minutes, during this maneuver, the thoracic outlet entrapment may happen and cause the neurovascular symptomology, like there would be pain, weakness, heaviness, tingling or numbness, or even pallor or paresthesias, or decrease in pulse in upper limbs. This is your Roos test for thoracic outlet syndrome, and an exam question that was asked as a video. So since the diagnosis is mostly clinical and the treatment is mostly conservative, if at all there is something that is actually causing compression of the thoracic outlet, you remove it. If it's a tumor, you remove it. If it's the first rib that is causing compression, you remove the first rib. That is all about thoracic outlet syndrome. The important thing to take away here is to know the names of the test and how they are performed. The symptoms are basically exaggerated to make the diagnosis. Now let's practice a few MCQs in order to appreciate what we have picked up today. Now let's look at the first question. Tinel sign is used for which one of the following? To assess the severity of nerve damage, to classify the type of nerve injury, to locate the site of nerve injury, or to assess the recovery of nerve injury. The correct answer is to assess the recovery of the nerve injury, right? It does not help us classify the type of nerve injury because it will never pick up neuropraxia. It does not help us locate the site of nerve injury because suppose it's axonotmesis and the patient presents 2 weeks later, the original site of nerve injury would have been changed, and it does not assess to help the severity of nerve damage. Okay? We have Seddon and Sunderland classification for that. Okay, so it helps assess the recovery of the nerve, whether the nerve is recovering or not. The best investigation is nerve conduction studies. A 17-year-old boy fell from motorbike on his shoulder and was diagnosed to be a case of Erb's palsy. Okay, all are true about the condition except it is the commonest brachial plexus injury and involves the upper trunks. Yes, true. Erb's point is at the junction of the anterior primary rami of C5 and C6. Yes, it is true. Loss of shoulder abduction and lateral rotation with loss of elbow flexion and forearm supination. That's pretty much the deformity that happens. Radioulnar joint pronation is lost and supination is normal. No. Supination is lost. So this is the false statement. Right. A 20-year-old male patient was involved in a single vehicle rollover accident. He presented with inability to abduct the shoulder and flex the elbow. So inability to abduct and flex the elbow. On examination, there was wasting of the supraspinatus, deltoid and biceps. Which of the following is the most likely diagnosis? Is it shoulder dislocation? Is it upper trunk injury of the brachial plexus? Is it lateral cord injury? Is it musculocutaneous nerve injury? Right. So what are the muscles affected here? Patient is unable to abduct means deltoid is affected. Flex the elbow means brachialis, biceps brachii is also affected. Supraspinatus is also affected. So these are the muscles that are affected. Shoulder dislocation will injure axillary nerve or musculocutaneous nerve, right? So axillary, deltoid and teres minor, musculocutaneous, biceps and brachialis, but not all of them. So this cannot be the answer. Upper trunk injury of the brachial plexus, yes. Erb's palsy, C5, C6 injury will definitely give you all of these affections. Lateral cord injury, No, musculocutaneous nerve injury will not involve the deltoid. So the answer here is B. This is classical case of Erb's palsy because the patient had a rollover accident where he had an injury to the shoulder. All are true about median nerve except, okay, a lunate dislocation causes its compression injury. Yes, lunate when it dislocates in the carpal tunnel will compress the median nerve. So this is true. Anterior trochleus nerve is its branch. Yes, it is true. It's a purely motor branch of median nerve. Hypoesthesia and wasting of the thenar eminence would occur if there is a median nerve injury. Yes, that is also true. Loss of adduction of thumb. No, adduction of thumb is brought about by adductor pollicis, which is the thenar muscle that is supplied by ulnar nerve. So this is a false statement. That is the answer. Right? Compression of nerve within the carpal tunnel produces inability to. So there is a compression of the carpal tunnel, and he's saying that this compression produces inability to abduct the thumb. Right. So if you have a compression in the carpal tunnel, your abductor pollicis brevis is affected, but abductor pollicis longus would be spared because that is supplied by the radial nerve. Right. So some amount of abduction can be possible. Okay. Adduct the thumb? No, because adductor pollicis is supplied by ulnar nerve. So compression of the median nerve in the carpal tunnel will have no manifestation on adduction. So this will also not be affected. Flex the distal phalanx of the thumb. Distal phalanx of the thumb or the interphalangeal joint of the thumb is brought about by flexor pollicis longus, which is supplied by anterior interosseous nerve way before the carpal tunnel. So compression in the carpal tunnel will have no effect on that. Oppose the thumb? Yes. Opponens pollicis. Opponens pollicis is the thenar muscle that is supplied by the median nerve after the flexor retinaculum. So compression over the flexor retinaculum or the carpal tunnel syndrome will manifest in the weakness of opponens pollicis. So opposition of the thumb would be affected and the patient will have inability to do that if there is compression of the nerve in the carpal tunnel. Right? Awesome question. Which of the following is a branch of ulnar nerve given in the arm? Ulnar nerve gives which branch in the arm? Is it the branch to FCU? Is it the branch to FDP? Is it the branch to FCR? Or is there no branch in the arm? The answer is none. There is no branch in the arm for median and ulnar nerve. Trick question here. Okay, don't fall for this. Which nerve is injured in the case of fracture of the medial epicondyle of humerus? So medial epicondyle of the humerus will injure which nerve? So which nerve is in very close proximity to the medial condyle of the humerus? Is it the anterior trochleus nerve, median nerve, ulnar nerve or radial nerve? The answer is ulnar nerve. Please remember ulnar nerve. Just behind the medial condyle you have your cubital tunnel where there is ulnar nerve. Radial nerve will get injured in Holstein-Lewis fracture. Median nerve and anterior trochleus nerves will get injured in supracondylar humerus fracture. Next, a boy presents with an injury to the ulnar nerve at the medial condyle, okay, of the humerus. All will be true about his presentation except. Okay, so it's an ulnar nerve palsy in the medial condyle of the humerus fracture around the cubital tunnel. All are true except. Paralysis of the third and the fourth lumbricals and all the interossei. Yes, true. Paralysis of the FCU and partial flexor digitorum profundus. Yeah, that's true. Hypothenar eminence atrophy and hypoesthesia. Yeah, true. Complete loss of sensation of fourth and fifth finger. That is also true, no? Not complete, not complete. So fifth will be full, fourth will be half. The devil is in the detail. So this is a false statement. Right? Is this clear? Right? It's 1.5 fingers. 1.5 medial finger. Next, a patient comes to the emergency department after binging alcohol the previous night. He had fallen asleep on the chair at the bar. Saturday night palsy, right? Right. Since morning, he has been unable to move his hand. A diagnosis of ulnar nerve palsy was made by the examining physician. What is the next line of management? So basically, the question is asking about ulnar nerve palsy. Please remember this. It doesn't necessarily have to be radial nerve palsy. It usually is, but other nerves can also get compressed rarely. So examiner is trying to twist here, trying to make you think of radial nerve palsy in terms of Saturday night palsy, only to give you an extra hint later in the statement. So be careful, read the whole question usually to make the diagnosis. So what should you do now? He has an ulnar nerve palsy and he got it compressed last night, so it's usually neuropraxia. So what should you do? Should you wait and watch? Should you give a knuckle bender splint? Should you go for immediate exploration of the nerve, or should you do electromyography testing after 2 days? Obviously, exploration is unnecessary. Electromyography within 2 days also is unnecessary. Wait and watch a knuckle bender splint. Better to go with a splint because it might take a few days to few weeks to recover, and you want to prevent contracture. Wait and watch is not a good idea. Go for a knuckle bender splint. Why knuckle bender splint? Because the patients of ulnar nerve palsy would have a claw hand. Next question. Injury to the radial nerve in the spiral groove results in all except. Okay, injury to the radial nerve in the spiral groove result in all except. Spares the long head of triceps. Yes, long head of triceps gets its supply in the axilla itself. Yeah. Triceps, lateral and medial head and anconeus are spared. No. They are the branches that go out from the spiral groove. So this looks like a false statement, but we'll see. Involves the muscle supplied by posterior interosseous nerve. Yes, obviously. Anything distal to the injury would be affected. Weakness in the wrist, thumb and extension. Weakness in wrist and thumb extension, basically. So basically the question is saying weakness will be there in the extension of the wrist and the thumb. So thumb drop and wrist drop. Yes, wrist drop will be there. So this is a true statement. The correct answer here is B. Because in the spiral groove, you supply the lateral and the medial head of the triceps as well as anconeus. So they will not be spared. A person is not able to extend his metacarpophalangeal joint. This is due to the injury of which nerve? So the question is not saying anything else except the metacarpophalangeal joint. The options are ulnar nerve, radial nerve, median nerve and posterior interosseous nerve. Now obviously extension means ulnar nerve has nothing to do with it, median nerve has nothing to do with it. Radial nerve and posterior interosseous nerve, what will you go with? Now, since the question is only saying the patient has inability to extend the MCP, it is not talking about the wrist, it's not talking about the sensory deficit. The safe answer is posterior interosseous nerve because he's talking about finger drop, not wrist drop. Right? So, pin palsy is the answer here. Next question is, a policeman found a person lying unconscious on the right lateral position on the road with bruises on the right arm and bony injury to the lateral aspect of the right knee. The lateral aspect of the right knee, bony injury is there. Nerve most probably injured is femoral nerve, radial nerve, common peroneal nerve or trigeminal nerve. So lateral aspect of the knee, which nerve are you thinking here? Because there is a bony injury, lateral aspect of the knee, nerve wraps around the head of the fibula. The answer is common peroneal nerve injury. And what will be the manifestation? Foot drop. Right. What is the splint you will use in foot drop? Foot drop splint or toe raising splint or ankle foot orthosis, AFO. Carpal tunnel syndrome can be caused by all of the following except diabetes mellitus, yes. Amyloidosis, yes. Addison's, I don't know. Hypothyroidism, yes. Not Addison's, definitely not Addison's. Addison's basically causes hypertension. It doesn't cause a carpal tunnel syndrome. So the correct answer here is C, Addison's disease. A patient can make a fist but can't flex his index finger. Which nerve is affected? A patient can make a fist but can't flex his index finger. This is pointing index. Without doing the options, you can say it is a median nerve, right? It's median nerve. A patient met with a road traffic accident, following which he cannot abduct his right arm. Abduction is affected. On examination, there is tenderness at the right upper arm. So there is tenderness over here. X-ray shows fracture surgical neck of humerus. You know which nerve is affected here. Which of the following muscle is also supplied by the nerve involved or the involved nerve? So which nerve is injured here? Without reading the options. It's axillary nerve, obviously, because there is a surgical neck of humerus fracture. Axillary nerve is involved. A patient is unable to abduct means deltoid is affected. And there is pain over the lateral aspect of the arm, meaning regimental batch sign. So which is the other muscle supplied by this nerve? It's teres minor. The answer here is teres minor. Very good. Chipmunk question. A patient came with complaints of inability to move his fourth and fifth digit, cannot hold pen, and he was not able to hold paper between the fingers. Which of the following side given below is the probable cause of injury to the nerve in the question? So which nerve is affected here in the question? The patient has fourth and fifth digit, inability to move, cannot hold the pen, and cannot hold a paper between the fingers. So card test is there. Cannot hold the pen means intrinsic muscles of the hand is affected. Fourth and fifth digit means ulnar nerve. Okay. So ulnar nerve will get injured where? Here, around this part, surgical neck of humerus, or around this part, or at the lateral condyle or the medial condyle. The answer here is at the medial condyle, at the cubital tunnel. So the answer here is T. Now, can you tell me which nerve will get injured here at A? Yes, it's axillary nerve. Very good, very good. B, radial nerve. Very good, very good. C, again radial nerve. Very good. D is ulnar nerve. Now, median nerve, where will it get injured? here. Supracondylar humerus fracture, median nerve, anterior interosseous nerve more than median nerve. That fracture will injure it. Okay, the answer here is D. Next, a patient came with a supracondylar fracture of humerus. Okay, very good. On examination, the patient is unable to flex the interphalangeal joint of the thumb. Which nerve is likely injured? No other symptomology is given. Only IP joint of the thumb is affected. Deep branch of ulnar, superficial branch of ulnar, a pin or AIN. The answer is AIN. Yes, clearly. Two hints were there. Supracondylar fracture of humerus injures anterior interosseous more than median, more than radial. First hint. Second hint, unable to flex the interphalangeal joint of the thumb. So which sign are we talking about? Yes, Kiel-Lewin sign or weak OK sign. Recent INI-SET question. The following test is performed to assess. Okay, this test is assessing which nerve? A posterior interosseous nerve, median nerve, ulnar nerve, musculocutaneous nerve. Which nerve? Answer is median nerve. What test is this? This is bend test. And which muscle are we testing here? Abductor pollicis brevis. Abductor pollicis brevis. The last question asked in the recent INI-SET exam is, if the outer sheath and nerve fiber remains intact, but the inner axon is damaged, which type of nerve injury is it known as? The axon is injured, outer sheath remains intact. Is it neuropraxia? No, in neuropraxia nothing is injured. It's a physiological reversible conduction block. Is it axonotmesis? Yeah, looks like that. Axonpraxia, I don't know what that is. Neurotmesis is the complete injury. So the answer here is axonotmesis. Okay, axonotmesis. And which nerve injury causes the deformity shown in the image? What is this deformity? Please don't say benediction sign, Pope sign. In benediction sign, Pope sign, first of all, it's not a resting deformity. You ask the patient to make a fist. Second, the MCP would be flexed. Here, the MCP is extended. The MCP is in extension. This is partial clawing of hand, and obviously you're noticing wasting here. Hypothenar wasting. This is your ulnar nerve palsy. This is your ulnar nerve palsy. Don't make this mistake on the exam. If the patient has a resting deformity with an hyperextension of the MCP, it is your claw of hand. Partial claw, complete claw. Partial claw is ulnar nerve palsy. Complete claw is ulnar plus median nerve palsy. Median nerve palsy will give you pointing index, benediction sign, Pope sign, or Ochsner clasp sign, where you ask the patient to clasp his hands and the index finger will remain open. With that, we have completed our nerve injuries. Try to practice as many MCQs as you can in nerve injuries because they are very, very valuable for your exam, not only in terms of orthopedics, but also in terms of anatomy.